Good afternoon, and welcome to the Understanding the PACE and Greenhouse Care Models and Their Collaborative Potential webinar. My name is Sue Hagler. This session is being recorded. This recording is for general informational purposes only and does not constitute business or legal advice by NPA or any of its participating members. Before we get started, I want to go over a few details with you. As you joined, you were automatically muted with your cameras off. We do want this to be a very interactive session, so at the end of the presentation, we invite you to join in with any feedback, comments, or questions. At that time, please feel free to unmute yourself and share your camera if you are able to as you speak. If you don't want to jump right in with your questions, please feel free to use the raise hand feature. We will also have the chat option being monitored throughout the session. Feel free to submit a question there at any time that will be read to the speakers during the Q&A period. If you are using the desktop version of Zoom, the raise your hand feature is located under the reaction emoji icons. If anyone has joined by phone, at the bottom of your screen, there are three little dots that you can tap to bring up both your chat and raise hand feature. If you have any trouble locating any of these features, please just let us know. I do want to encourage you to post questions for the speakers in the chat, but also feel free to engage your colleagues with your observations throughout the webinar as well to promote networking. I would like to introduce Sean Bloom. Sean is the president and CEO of the National PACE Association in Alexandria, Virginia. Sean, I am now turning it over to you.
Thank you, Sue, and thank you to everyone who's taken time out of your busy day to join us. Been working with the Greenhouse folks for a while, and I think we have a really good session that you will find informative, as well as hopefully spawn you to think creatively about collaborative opportunities between and among PACE and greenhouses. In today's session, we're going to give a very brief, and I want to emphasize brief overview of the PACE model of care. And following that, we're going to give a brief overview of the greenhouse model. And then we're going to conclude the presentation component of our session here with a case study. PACE of Southeast Michigan actually operates greenhouse right on the same campus as PACE. So we're going to talk about how that works. And then, as Sue mentioned, we're going to leave aside a fairly significant part of the end of the session for dialogue. This will be an opportunity for you to ask questions in the chat box. And then we're also going to have some dialogue, I think, potentially among the presenters about collaborative options and opportunities that may exist between PACE and greenhouses, which are in common markets. Following the call, we will be distributing to everybody on the call a document which will identify where there are markets that are crossover. And our hope in sending that to you, along with the contact information for those two models in similar markets, would be that you reach out to each other and discuss and identify potential collaborative opportunities that will be identified during this session. Many of you on the phone, probably all of you on the phone, having worked in the long-term care arena for quite some time, are probably aware of PACE or aware of greenhouse. I certainly have been for many years, and it's always dawned on me that we are kind of philosophical kissing cousins in many ways. In many ways, what both of our models really strive to do is to create kind of an intimate care delivery approach that is very person-centric, and it's kind of breaking free from our traditional service settings that we have in this country. So at the end of this, again, I would really hope, our hope at the end of this conversation and discussion today is that you're inspired enough to kind of begin thinking through, in the context of PACE, whether there's a greenhouse in your market that you might want to go and talk to. It stands, one thing to keep in mind for the greenhouse folks on the phone, on any given day, nationally, the average is about 5% of our enrollees in PACE are in a contract skilled nursing facility. I'll say it aspirationally, wouldn't it be great if someday we can really think about allowing those individuals to receive that kind of level of skilled or institutional care in a greenhouse? Alternatively, and as it relates to greenhouse, to the extent that you find PACE attractive, there are many and emerging growing opportunities to develop PACE. And there are a lot of collaborative opportunities in between those two scenarios that I mentioned. So with that, I'm going to go ahead and get started. As Sue mentioned, if you have questions or comments, there'll be plenty of time in the end, but if you feel the need to clarify something, please put it in the chat button and I'll do my best to address it. So we tend to talk about PACE in the context of the 4 C's. First and foremost, we are a community-based model of care. We strive to serve individuals in their communities where they live. And one way to think about a PACE program, within the PACE market, there's a PACE center. And typically it's about a 45-minute driving radius around PACE, which encompasses those that we strive to enroll and serve in the community. But at the end of the day, one of the measures of our success is allowing individuals to remain living independently as possible in their communities, in their homes. We're comprehensive. You know, one of the things that I think makes PACE very unique, we're really the only fully integrated model of care in this country. And what I mean by that is when an individual enrolls in PACE, they agree to trust us to provide, identify, organize, and provide the full range of primary, acute, and long-term care services. So they're really, for lack of a better expression, there are no other providers that we are not responsible for either arranging with or directly providing ourselves. The vast majority of services provided by PACE are provided directly by employees. We do contract out for hospital care and medical specialists routinely, but other than that, for the most part, we provide all required services ourselves. And they are in fact comprehensive. And technically the federal reg says that we must provide all Medicare, Medicaid, and all medically necessary services. We're also capitated. And this is a really important part of not only what we do, but how we do it. We receive fixed capitated payments from Medicare and Medicaid each month that do not change based on the service utilization or future needs of those that we serve. The Medicaid payments are calculated by states to be less than what it would otherwise cost the state to serve that individual in traditional fee-for-service. And the general rule of thumb is those Medicaid capitated payments are generally about half the cost, monthly cost of a nursing home. On the Medicare side, it's called a risk adjustment model, whereby each individual PACE enrollee, based on their demographic and diagnostic characteristics, that data is fed into a risk adjustment model at CMS. And out of that comes a risk score, which in the case of PACE is about 2.5. And what that really means is we're about 2.5 or 250% more costly than the average Medicare beneficiary. So that capitation is generally calculated on the basis of average Medicare cost per county multiplied by 2.5, and that's our payment. And then lastly, we're coordinated. And I always like to say that the interdisciplinary team, which is really, I think, the heartbeat or the DNA within PACE, is a group of employed individuals that meet every day in what's called the morning meeting. And that interdisciplinary team, which I'll show you a graphic in a little bit, is comprised of physicians, nurses, social workers, physical therapists, occupational therapists, representatives from transportation, home care, dietitian. I think you get the picture. It's really a comprehensive array of all the types of individuals representing the services that our folks need. And that coordinated interdisciplinary team is really what works the magic within PACE. So to be eligible for PACE, you must be 55 years of age or older, living within that service areas I mentioned. And you can have multiple centers, but generally the rule of thumb is you don't want anybody sitting on a bus more than 45 minutes or so. You must be certified as needing nursing home level of care by the state in which they reside. And then also what the team looks at carefully is, are they able to live in the community safely with the services of PACE at the time of enrollment? This is best interpreted as meaning if someone's already in a nursing home, to the extent that we can transition back to the community, that's certainly a possibility. But I think our ability to really best meet the needs of individuals are those that reside in the community that are wishing to avoid institutional placement. I won't go through all these, but in many ways, a lot of people observed, several people observed just last week during a presentation, in many ways, we followed a very similar path of hospice in the sense that there were a group of very motivated individuals that wanted to do things a little bit better or a little bit different. And we had a demonstration program. We then, after that demonstration program was deemed to be very effective, that is the unlock model of care, then Congress authorized a replication to see if it worked elsewhere in the country. And then after a lot of analysis and research, in 1997, we achieved what's called permanent provider status. And what that means is we are a permanent Medicare benefit and an optional Medicaid state plan service. So where we are today, we've got 144 sponsoring organizations, and they operate among them 272 PACE centers, which really indicates that most of them are, on average, they've got about almost 2 centers each. You can look at the map. One thing I would like to point out about the map is we're on the verge of opening up a couple new states, actually 3 new states in the Midwest: Kentucky, Illinois, Missouri. And there are significant efforts underway in other states to either open them up or expand where PACE already exists. And we are beginning to see, we are on the front end of, I think, an unprecedented degree of growth that we anticipate, in particular in the short run over the next couple of years. But I am confident that looking forward over the next 3 to 5 years, we're going to see continued growth coming out of COVID. So this is just an example of our growth trajectory. You know, in my view, we still serve a very, very small proportion of the people that would benefit from PACE. And so we have, from policy perspective, we have a very ambitious strategy to expand access to PACE around the country through removing federal and state policy barriers and creating opportunities for more growth of PACE. So really, you know, one of the things I think that's really important to understand about PACE is just the philosophy. You know, when our teams get together, I think individual driving goal is really to allow individuals to stay in what they consider to be home. We do that by really focusing on maintaining autonomy, in particular, functional autonomy. That reflects a little bit of my bias, but a very significant focus on allowing individuals to maintain the highest degree of function as possible, as well as social engagement and cognitive function. As you can imagine, I referenced the transportation considerations. Transportation is a very, very significant, very important, as well as very complex service that PACE programs organize and provide to our participants. It really helps us to not only transport people to and from the day center, which prior to COVID, they would come to about 2.5 days a week on average, but it also is transportation that takes them to medical specialist appointments, social outings, and those type of things. Again, very strong emphasis on PT and OT and other Medicare services, many of which are very confined in what can be provided based on very kind of standard uniform Medicare rules, which dictate the degree to which you can provide PT and OT. Our capitated payment gives us the flexibility to do whatever is necessary for an individual. And it's probably important to note that it's the incentives that capitated full risk payment in PACE provides us to really do whatever we need, regardless of what would otherwise be limited in fee for service. Very small in scale. I referenced the IDT. Each of those IDTs manages the care of about roughly 200 people. There's variation there, but it's about 200 people. And again, they meet every day. And the process they use is essentially a circular process, if you can envision that begins with assessment, comprehensive assessment across all those disciplines, the development of an integrated care plan, the delivery of services, and then a measurement or assessment of how well they're doing. And if there's a change in condition, much like the MDS, we then restart the assessment process. This is just an example of services that are provided. I'm always struck with this slide that it does not indicate, I think, all the creative things we do in between the lines here, whether it be build a ramp so individuals can get in and out of their house, put an air conditioning in the window during the summer so they can avoid hospital stays due to COPD or CHF, and a variety of different things. We have immense flexibility in the use of the resources we get through the capitated payments to meet their needs. And again, you know, it's one thing, it's really important. You know, I really value case management and those type of things. This is really integrated team managed care. Real-time discussion across all the disciplines about what individuals need and would benefit from to optimize their health and mitigate unnecessary hospital and nursing home stays. So it's really team managed care versus individual case management. And again, that third bullet is really the circle, as I call it. And then we really focus on and value significantly primary care, because often it can be in the absence of good primary care or sufficient primary care, it can be the precursor to permanent nursing home placement. So this is just a graphic depicting what the team looks like. And again, if you've ever been to a PACE program and sat through a team meeting, it's kind of one of those you get it moments when you hear how they talk about things. And it's very real time. It's magical. It's really the magic within the PACE model of care. So I mentioned capitated pooled financing. It is worth noting that about 90% of the people served by PACE are dually eligible, meaning that they're eligible for both Medicare and Medicaid. About 9% are Medicaid only, meaning they states are responsible for the full range of their healthcare needs. And then we've got 1%, maybe less than that, of individuals who what we refer to as Medicare only. These are individuals that have resources above the Medicaid limit. This is an area that we're very focused on. As you might know, the vast majority of people in this country that need long-term care, at least in the beginning, begin as private pay. Many of them spend down to Medicaid limits, but we're really looking at trying to provide and remove barriers to allow private pay to enter PACE. So this is what our revenues look like. About 60% of our revenues come from Medicaid, 40% from Medicare, and these are the 2021 means. It is worth noting there's significant variation across the country based on the county and the state within which PACE programs reside. But as you can see on the Medicaid side, and it bears repeating, with that 4141, we were responsible for unlimited nursing home placement and all the other services. And on the Medicare side, and these dollars, by the way, get combined, but taken together, that's $7,000 a month. We are responsible for all hospital care and related costs. Lastly, we're fully recognized Part D providers. Individuals that enroll in PACE must get their Part D drugs through PACE, and we administer the benefit on their behalf. Provider-based model of care, very tightly controlled, serves exclusively a nursing home eligible population. Great outcomes. Only about 5% of our people on any given day are permanently placed in a nursing home. Our folks use about, on average, 3 hospital days a year, which is about the average Medicare beneficiaries utilization. And we have very low disenrollment rates and very high participant and family satisfaction. So in challenges for new providers, think about people rather than events. Abandon the assumption that more is better. Not all aspects of care are clinically based. If we had more time, I could tell some great stories, and embrace the importance of a consistent care delivery system over time. So if you want to learn more, this is our website where you can go to learn more about PACE and a variety of different tools we've developed and make available. So with that, I'm going to now turn it over to Alex, and he's going to give an overview of Greenhouse. Alex?
Yes. Hello, everybody. I am Alex Spanko. I am the Communications Director at the Greenhouse Project, and very excited to be here. I want to thank Sean and the team for inviting us, because while the Greenhouse Project's primary goal is getting rid of the institutional nursing home as we know it into something better, something that truly is home, we're not we're not partisans. We love home health. We love PACE. We love adult day programs. We love anything really that will provide the care that elders want in the setting that they prefer, or care that elders need rather in the setting that they prefer. That's far more important to us than any setting. And for people who prefer to live in a communal setting, people who would prefer to have that kind of social interaction, but don't want to live in sort of a traditional nursing home, the Greenhouse difference can make a real difference. I like to start out all these presentations by borrowing a phrase that we talk about all the time, which is, what would you need? And basically that means that values don't really change as we age. What you need now to feel at home probably won't be all that much different from what you need to feel at home when you're older. Right now, admittedly, I'm probably far away from retirement age, but I kind of know intuitively, and we all sort of know intuitively what you need to feel at home. So for me, that would be a kitchen where I can experiment, because that's something that makes me happy in my free time. For me, it would be the ability to watch the Mets and Islanders, because I'm a masochist and I also enjoy watching sports, and that's a really important thing for me. And also a private room, because I'm an only child, and I shared a bedroom once in my life. When I was in college with a stranger, and I don't want to do that again. So those are very basic things, and they seem very simple, but they go a really long way toward making someplace feel at home. So think about that internally as we kind of go through the presentation, and remember that our overarching goal is to provide those things that we need to really feel like home. So if you see here, I'm not going to get into too many specifics about sort of the operations of the Greenhouse model. I really want to, and one of the reasons I designed this presentation the way I did, is to highlight these pictures, because I really want, seeing is believing with the Greenhouse model. So if you look here, the bottom left picture, that is a greenhouse development. It's indistinguishable in a lot of ways from just a subdivision in a traditional single-family home area. And that's by design. We want to make sure that when you go into a greenhouse and when you visit a greenhouse, it's not just home-like. It's not just, one nice living room, but the rest is institutional. That's not how it works. We don't have long hallways. We don't have medicine carts. You are looking at single-family homes where no more than 12 elders live in all private rooms. Oh, if you look at if you also look at the top on the right here, where this woman is walking outside, that also looks like a single family home. That is the goal. There's also a connection to nature. You know, one of the things we learned during the coronavirus pandemic was social isolation and isolation from nature are extremely, extremely deleterious to the health of elders and really everyone. We don't want to keep people locked inside. We don't want to keep people locked away from their loved ones. We don't want to keep people to be locked away from fresh air and exercise, no matter your physical or cognitive abilities. So a key tenet of greenhouse design is unfettered access to secure outdoor areas. You're not supposed to, you know, if you're at home and you want to go take a walk, you don't have to ask permission to go outside. That's a key goal of the greenhouse project as well. You can access these outdoor areas. You can garden like the gentleman and the woman in the top left. You can take a walk with your grandkids or your nephews or your friends, like the family on the bottom right. The whole goal is that it's not just home-like. We kind of bristle a little bit at that term because that is a term that gets used often, home-like. It is your home. It's a place where you feel safe. It's a place where you're in control of your day-to-day decisions. And the connection to nature is a key part of it, not just as a physical activity, but mental well-being, sunshine, sunlight, fresh air. These things mean just as much as, or contribute just as much to someone's physical and mental health as medication and medical attention. So we really emphasize this. It's a key tenet of our design. Again, a real home. Right there on the bottom left, we have private rooms. That is a key tenet of the greenhouse model, is the idea of everyone has a private room because it's just a sort of a baseline of human dignity, right? There's also a private bathroom inside at every resident room. I still can't believe in this country we have, nursing homes where people have to line up in a shared hallway just to perform the act of bathing. Makes you feel like does not make you feel like a human, does not make you feel like you're living at home, right? So private bathrooms and private bedrooms are sort of the foundation, but that's just the start, as you'll see over the course of this presentation. But if you look in the top right there, you have a sun porch, you have a living room, you have a place where you can gather, where you feel good about having guests over. Because again, we have a problem in this country where the traditional nursing home, as I'm sure all of you know, were based, developed 60 years ago now, based on the hospital model of care, designed for brute force efficiency and not actual quality of life. So just by transforming that physical space, you're saying this is not a medical setting. This is not a place where you're going to be sick. This is a place where you live and you receive those day-to-day supports that you need without sort of all of the signifiers of medicine, hospital, and unfortunately death is something that we associate with these facilities because it's sort of seen as other, right? It's not home. It's a place you go once you can no longer live at home. And the entire goal of the greenhouse design and the greenhouse philosophy is to make a place that is home because it is your home. It's not just home-like. Also, so you may have seen so earlier on I showed you the sort of single family home design. That's just one flavor of greenhouse. We realize that that's only possible in certain areas. Rural areas are where the greenhouse model first sprang up in 2003, Tupelo, Mississippi. We've had a lot of success in Arkansas, and part of that is because there's just available land. You can build out the greenhouse to its fullest design, which really emphasizes single family style, individual housing units, no more than 10 to 12 people per unit, plenty of outdoor space, plenty of nature. We realize that that's not always the case, so you can adapt. So if you look at the building on the right there, each floor of this building is its own greenhouse. So it's instead of having a standalone unit with 10 to 12 elders, you have a floor that's its own community with 10 to 12 elders. So each at the community on the left there, it's from a different community, but it really illustrates something that I think is very cool. It shows a gentleman out there waiting for an elevator outside a front door. You see that front door, that is the actual front door of that community on that floor within the larger building. One of the key tenets of the greenhouse design program and design operational program is that front door is sacred. That's the front door to your home, whether it's a standalone greenhouse, single family style, or one floor of a building. You can't just walk in there. You have to ring the bell and the staff or a resident has to let you in. It's the same thing at your house. If you have a maintenance person come over or if you have a delivery, the person can't just walk into your house, but that happens all the time in nursing homes. So that is a key, very small thing that we try to enforce, but it really goes a long way, again, to creating home. And these pictures in particular show how it doesn't have to be, you don't need to have acres and acres of land to make a greenhouse sort of community work. You just need to have the design principles, you need to have creativity, and you also need to have sort of dedication to elder-directed care that takes place in a real home. I include this slide to show that it's not just that we try to, sorry, we don't try. We have more educational requirements than a traditional nursing home. The Cna training is the required foundation. The CNAs are the drivers of the care in the nursing homes. We don't call them CNAs though, we call them shabazin, which is it's a Persian term referring to a caregiver based on a legend. And in addition to the specific Cna training, they have to require 80 hours of food handling, CPR skills, home maintenance and management, and 40 hours of dementia care, critical thinking, communication, teamwork, all that good stuff. So the idea is that it's not just the traditional sort of baseline training for nursing homes. We at the Greenhouse Project provide additional training and ongoing supports to make sure that workers and staff, workers and residents receive the best environment possible. So I hinted at that with the education, but the greenhouse model is way more than just bricks and mortar. It's also about the universal caregiver model, or the shabaz, singular shabaz, plural shabazim. Unlike in a traditional nursing home where it's sort of a top-down structure where the nurses kind of control day-to-day operations and everyone reports to the nurses, it's a universal caregiver role, the Cna shabaz, and they work together in a team to dictate the day-to-day operations of the greenhouse community. So that means not only are they providing care tasks, but they're also cooking. You see in the kitchen on the top right there, where you have a resident, an elder, and a shabaz cooking together in a kitchen. They prepare the meals. They also do light housekeeping work, such as linens and general cleaning. So this universal caregiver model has a couple of different advantages. One, it makes it truly like a home because it's not medically focused. You know, again, we're not trying to make a community where it's all built around healthcare. Healthcare is provided. There are still registered nurses. There are still, doctors and specialists who come in. But first and foremost, it's a home, and home is about convivium. Home is about sharing meals. Home is about cooking. Home is about feeling comfortable. So the Shabazim work with the residents to develop menus. They're encouraged to share family recipes, traditional recipes. The Shabazim will even go shopping to provide favorites for individual residents. They're encouraged to cook and participate in the cooking process. They're encouraged to bring guests. The universal caregiver also, outside of sort of the cultural benefits, it's also efficiency. Providers who have adopted the greenhouse model devote so much more of their resources toward direct care, toward the Shabazim, and less toward overhead. You don't have the typical silos that you have at a nursing home operator. You don't have a housekeeping department with a housekeeping leader. You don't have a dietary department with a dietary leader. The self-managed, self-directed universal caregiving team forms the core. So you spend less money on overhead and administration and more money on what we all know really matters, which is direct resident supports. You also spend more time with residents because you can do multitasking. Think about it in your own home. Maybe you have kids, maybe you take care of an adult family member who requires some assistance. You don't do your tasks as, okay, now I am cleaning, now I am doing cooking, now I am folding laundry. You can fold laundry and have a conversation with a resident, find out how their day's going, find out who's coming to visit later on. You can cook and you can ask somebody how they're feeling. These are small things. I know it sounds kind of obvious, but built together, when you add the sum total, you have a staff that knows their residents way more intimately and can identify changes in condition, can head off problems, and can do all of these things because they are directly interacting with the residents, and they're not sort of existing in these silos where the goal is efficiency and the goal is checking off boxes. You get to know your residents, you get to know the staff, and you create a true community. These three show the sort of range of options. The Greenhouse Project is not about, obviously our number one goal is we would love to see all traditional nursing homes replaced with these kinds of alternatives, greenhouse alternatives. That's not always the case, and we acknowledge that. So we also, as an organization, provide a variety of services to try to bring as many of these principles into traditional nursing homes as possible. So for instance, you can have the universal caregiver model at a traditional nursing home. We have a best life dementia care model that really focuses on each person's abilities and desires, doesn't see people as a diagnosis, but sees people as people who just happen to have cognitive issues. We also have culture change, where you can change the culture. You can incorporate all different kinds of these greenhouse principles into a greenhouse cultural transformation journey, where you try your best to incorporate as many of these principles. So for instance, you can try to convert everything to private rooms. You can try to adopt the universal caregiver. You can adopt elder directed services. That's another key part of the greenhouse difference that I want to really touch on, is that we make sure that the elders are the ones in control of their days. I mentioned earlier, what would I need to feel at home? Another thing I would need is not being woken up to have breakfast at 7 in the morning, because that's when breakfast is made. I'm a night owl. I probably will be for my whole life. I have been so far, and I don't see that changing. So when I'm older, if I'm retired and I'm living, if I require congregate care, the last thing I want is someone waking me up at 7 in the morning, because that's when everyone is eating. It can be as simple as just, when would you like to eat breakfast? And it's prepared fresh for you at 10 a.m. instead of 7 a.m. Or maybe you don't like eating breakfast at all. A lot of mornings I don't. We respect that in the greenhouse model, because you don't give up your rights and you don't give up your sense of self just because you require extra physical and cognitive supports. Just want to give a quick shout out. We are doing a development workshop in person in Pompano Beach, Florida. If you're really inspired by this and you want to tour a greenhouse, COVID pending, take a look at our website. We are doing an on-site tour so you can see what it actually looks like in practice. So if you want to know more, you can visit us at thegreenhouseproject.org. Send me an email, aspanko@thegreenhouseproject.org. We're really excited at the potential of the greenhouse PACE overlap, because again, at the Greenhouse Project, we're not just about creating small homes. We're not just about creating our unique model. We really are about creating a full continuum of care for elders, no matter where they are in their journey. Home care works great for a long time, until people may want to move into a communal setting. Communal settings work great as post-acute, but maybe people really want to return home. Maybe you don't even need an in-home person. You don't need in-home care all the time, but you just need a place to go during the day. We fully support a broad range, a depth and breadth of services that meet elders wherever their needs are at any given time and evolve with that time. And that's why we think the PACE greenhouse connection can be so vital. And with that, I want to throw it over to Mary Neighbor, who's going to walk through a case study of how both of these different programs can work in harmony together. And I hope you get some ideas from that as well. So Mary, take it away.
Thank you, Alex. And thank you to the PACE team for inviting us to share our story about how we have worked together with the Greenhouse to create a living environment for our participants that, as Sean said, is not institutional. So let me first tell you a little bit about PACE Southeast Michigan. We were one of the pilots for Medicare way back in 1994. And so we've been serving Southeast Michigan for many years. I would say we experienced rapid growth starting in around 2015. And we now have 6 centers in Southeast Michigan, which are counties around Detroit and Detroit as well. We'll have our 7th center in spring of this year, and we're serving nearly 1,400 participants. The Greenhouse Partnership Model is in Detroit, and it's on our Rivertown neighborhood campus. And Presbyterian Villages of Michigan, which is really a senior living company that owns a not-for-profit that is partial owner to PACE Southeast Michigan, they had a vision that they wanted to create affordable housing for seniors in an urban setting. And that's exactly what they did. This vision started back in 2008 when Detroit was really at probably one of its lowest points. And yet they were able to rally many volunteers to help make it happen. In 2013, they launched the center. So it's a full neighborhood campus. It has independent apartments, assisted living, greenhouses, and a PACE program. And the greenhouse actually was beginning development when I arrived at PACE, which was about 7 years ago. And I learned about the greenhouse, nursing home, et cetera. I had been in a health system world and discovered what a beautiful model the greenhouse really was in comparison to what I was used to, which was institutional nursing home. And as we talked, and I learned more about PACE and the fact that 5% of PACE participants actually end up in a nursing home, it seemed to me we could really work together more closely about how this could work. We modified the thought that it would be a nursing home for Presbyterian Villages of Michigan, and actually turned it into a home for the aged. So that is actually how it's licensed in Detroit, as a home for the aged, and licensures with the state of Michigan. So we have on a 4-story building, we have 2 stories. The 3rd floor is serving 10 participants in a home. And the next level, which is the 4th floor, would be another 11 participants. And then we have a rooftop deck as well. This modification allowed us flexibility to move away from some of the state restrictions that the nursing home experienced, and gave us a little more flexibility in our partnership. So one of our goals was really to move away from that whole concept. If we, as a PACE program, want to keep people out of nursing homes, and that's our mission, then if 5% of them ultimately need more care like they provide in a nursing home, this partnership could actually be the alternative. So that's exactly what we did. I'd like to show you what the rooms look like so that you could see kind of how it feels. So would you go ahead to our pictures? So you can see that's our front door, and both floors have that front door. And as Alex was saying, we honor all the concepts of the greenhouse. So you ring the bell to go in, our caregivers ring the bell to go in. And it is a very close partnership between the Shabazims and the PACE caregivers. And I'll tell you more about that when I talk about the operating arrangement. But you can see that's the kitchen. There's the common living area. And you can see behind the living room sofas, you'll see the dining room where they eat together. If they choose, they could eat in their room if they wish. It's truly, as Alex describes, people eat when they want to. They can prepare their own food if they wish, or the Jabazim will help depending on what their needs are. That is the view of what I would say the start of a bedroom. They really embellish it with their own chair, maybe a favorite chair, their own photographs, however it is that will personalize it for them. So that's kind of in its raw state. And then this, because we're in an urban setting, right in the city of Detroit, there's a patio that's like a balcony offside the living room, and they're able to overlook part of the city, which is very cool. And what's really cool was that the building is a reconverted old pharmaceutical building that was in Detroit for a very long time. And you can actually, from some areas, see the lake, which is beautiful. It also has an upper deck, which we don't have, a rooftop, which we don't have pictures of, but on the rooftop, our participants are able to grow vegetables and flowers and different things, and actually host family events on the rooftop. There's a barbecue grill and that sort of thing. So it allows for a larger group to meet and gather, which has been really great. You can see we have barbershop and care services to make sure they're groomed well. And then this is, of course, is one of our participants as he came into his new home, and that some family members, some caregivers, and kind of just shows you how it is. We do a little gift when they come in. It's a great partnership. This is one of my favorite photographs. This is one of our participants who baked a cake. And that kind of shows really the independence that's allowed, very different than an institutional setting, those of you who've experienced those. So that's the beautiful thing about the greenhouse model, is that it really does allow people to live and do as they can, because some of them can do more and some of them can do less. Okay, with that, I'm going to keep going and talk about a little bit more about the logistics of how we made it work. So one of the most beautiful things is the greenhouse and PACE share common philosophies, which makes it very easy to kind of resolve some of the contract and agreement issues, because we want people to be independent and not in an institutional setting. We were able to come up with an agreement whereby it could be a win-win for our participants to be removed from nursing homes and placed into this beautiful home. They would get a higher quality of life. And for us, it would be a lower cost per day, because we worked out an agreement where the cost of care is lower to be in the nursing home, because we're supplementing the care. We're providing all the care that is needed for them to live there. And the way, and I'll tell you about that in a minute, how we worked that out. But that's probably the most important part of this agreement, is that we committed to paying for every room every day. So everyone that lives in the greenhouse is a PACE participant, and that makes the model work. Now, Presbyterian Villages of Michigan owns and operates it, so they employ the Shabazims, and then we employ all the PACE staff that provide the care. And I'd like to talk a little bit about, since we signed an agreement in 2016, we started to enroll in 2017. We've had about 128 participants live there, most of them till end of life. That's the goal, is to keep people in that environment for as long as we can. How we made the agreement work. The Shabazims, as you say, as Alex mentioned, provide the 24-hour supportive care. However, Monday through Friday during the day, they can come down to the PACE Center and get rehab services, clinic care, activities, cognitive stimulation, be with their friends, however they wish to use the PACE Center. And some of them go up and down throughout the day. Whatever they choose is up to them. How we learned to do it well was that we assigned the same nurse case manager, the same social worker, and the same LPN to provide care to all the participants who live in the greenhouses. And so that's what we do. And they can come back and forth to help one another whenever they see the need. And in fact, the doctor will even do house calls, because it is right on the same campus. Another beautiful thing is that the greenhouse team is familiar with our practices. And so they know if there's an emergency, they call our number, which puts us in touch with our ambulance service after hours. We have paramedics that go right to the greenhouse and can assess the situation, talk to our doctor, and know what to do. So they stay inside the care loop, as I say, the PACE care loop. The teams, over time, we learned many things. The teams meet every week. The PACE team, the caregivers, and the Shabazim, so that they can talk about the participants, what their needs are, if anything's declining, what else can we do, if there's family issues, whatever the issues are, they work out and they problem solve together. And I will say that it's worked very well. We've had many, many learnings along the way, as you might imagine. You know, we start with these great ideas, and then the practicality of how do you make it work every day. And what I would say is that we are blessed with amazing caregivers who put the participant at the center of what we do. And they are always resolving to make sure that they have what they need. And that is a critical piece. Because when there's difference of opinion, when you make sure that the participant in what they desire is at the core of what you're talking about, it helps resolve the matter. So a couple of key things we learned. Early on, you need to clarify the roles. Who's going to do what? How often? What can be expected? What time? When? How do we support one another? And another thing was around the admission criteria. It is important because Home for the Aged has some admission criteria. And we have a desire to put participants in there that are in nursing homes or ready to be going into a nursing home. That's kind of our criteria. Then what are the care needs that are required, and can the Shabazims provide them in the after hours? And those are the things we talk about. In addition, as someone is living in the environment and their condition starts to decline, what additional support is needed? And that the teams have to talk through. And sometimes PACE has to step it up, and sometimes PBM has to step it up. You know, the greenhouse has to step it up, and together we make it happen for the participant. Our goal is that they remain in that home till their end of life, that is their home. And that's what we all have to remember. Of course, COVID presented some new challenges, and we had many new learnings with COVID as well. I will say another key point is that you got to be aware that this is not assisted living. For it to be advantageous to PACE, it's assisted living elevated. It's really with the additional support, because if they're coming out of a nursing home, if they're ready to go into a nursing home, their needs are greater. And we've got to be able to ensure that that partnership provides those services. And those are the things that are constantly needing to be talked about. We learned a lot. And so one of the things that I did want to also share is that we opened up our newest center in Pontiac. And we had the opportunity to build a greenhouse-like model on the second story. And it has 12 bedrooms and a common living and a common space for people to live. And we currently have 5 residents living there now. And this challenge for us, and we own and operate it, so that means the staff is ours as well. And we do have a nurse that oversees it. She's kind of in and out just as additional support. And they're also assigned the care team as well. So they get a nurse case manager, social worker, that sort of thing. Our greatest challenge has been staffing since COVID and finding enough staff for the 24 hours that we need. So I'm a firm believer that this is a great partnership for PACE and the greenhouse to provide a living environment for our participants who need something other than institutional living, but need more than an assisted living can provide. And I would invite you all to explore those options, because they're, if you can be creative, because we are the payer as well. So with that, I'll turn it over back to Sean for questioning.
Thank you, Mary. We've got a lot of questions in the chat box. So many, so I'm not sure how we're going to address all of them. This is great. Let's see, the best way to go through them. Yeah, someone mentioned that we are missing recreational therapy in the services provided. That's an oversight. Recreational therapy is a part of the team. And then there's a lot of questions about how can you incorporate physical medicine and rehabilitation doctors, physiatrist. I don't know whether Hassan, you were referring to PACE or greenhouse, so maybe you can clarify that. And then there was a series of questions on Capable. And for those of you that may not know, Capable is a model of care that was developed by Hopkins that is a fairly intense home-based approach to helping to mitigate the use of nursing home, hospital, and other healthcare cost. And I think the question is really about, does that make its way into PACE at all? And I actually would look to some folks that work in PACE to see if there's, if you've collaborated at all with individuals in the Capable program. So I'll give you a few minutes to do that. And if you have, you can unmute your phones and chime in a little bit. And if not, I'm just going to keep moving. And if you unmute your phones, feel free to just to kind of jump in. There's also a question about, and this I think is directed to Alex. What do you do when residents don't get along?
Well, that is a very good question. We try to approach these things in a restorative way. And again, keep in mind that the greenhouse model is, so as the National Greenhouse Project, we have developed and we continue to enforce the standards of the model and improve the model. Each individual community is run by its own provider group, mostly nonprofits. We have one for-profit provider group that has adopted Greenhouse. Vast majority are nonprofit, mission-driven, a lot of religiously affiliated organizations. So when I talk about how we do things, there's going to be some variation there. But we, more than, we really try to enforce having productive restorative conversations, especially when you're talking about people who have cognitive challenges. I think the number one strategy is just to put people in a separate unit, is to put people away, avoid the question. We don't do that. We really focus on inclusion, and we really focus on making sure that everyone is included, no matter their physical or cognitive abilities. So we really do focus on trying just conflict resolution, trying to provide mediation, trying to talk to just trying to talk to people. I've never been in that situation myself, so I can't give you a detailed answer, but I would say in general, we really do not believe in segregation of anyone based on not getting along, or whether that's driven by cognitive challenges or physical challenges. Again, it's all about trying to honor people where to meet them where they are. So conflict resolution is a key part of that.
And I would argue, go ahead, Mary.
Yeah, I was just going to say, we of course have experienced that with people, whether it's through their own cognitive decline or just temperament. And I would say that's what happens. The team does some conflict resolution. Sometimes they'll involve the caregiver. Sometimes they'll involve family if there's family available, but they typically work it out. Sometimes they just give people some space, right? They find a quiet spot and let them figure that out. So I have not heard of any situation except where we had some really significant dementia issues where they've had trouble with combative, participants that's combative. That's the only one stories that I've heard about that you have trouble with.
And I think conflict between two human beings is not something that's unique to Greenhouse or PACE, but I think as Alex and Mary mentioned, I think we kind of do what we can in those instances. Joseph Ronnie has a question. You raised your hand. Maybe you want to unmute your phone to be able to pose the question, Joseph, if that's the case.
If I could. Am I live?
You are live.
All right. This is just fantastic. Absolutely. What you're doing is fantastic. So just a couple of questions. Are they classified as custodial care in Michigan? I'm in New York. So are you in the residences, or is it custodial care where you have some responsibility for their oversight?
So I will say that the way we've got it set up is that in the home for the aged, the Shabazims provide the supportive care, which is the universal worker concept. And PACE provides all the additional care, the wraparound care, primary care, rehab, all of the other services that are needed for them.
But it's not custodial.
When you say custodial, I would need you to define it, because that's not a term that we use.
As far as in a skilled nursing facility where they are responsible for the person, right? You have different.
I would say PACE is responsible for the person's overall care 24 hours. We take that responsibility. Yes, that's ours.
Now,
Joseph, are you raising a question about state licensure?
It's tied to that, but I didn't want to get too deep into that.
Yeah, it's us. It's on us. It's on PACE. These are PACE participants.
Now, who owns the residence?
Okay, it's owned by the greenhouse that we partner on is owned by Presbyterian Villages of Michigan.
Okay.
Which is a 45% owner of PACE. We're a not-for-profit. The other owner is Henry Ford Health System. They own us 55%. And Presbyterian Villages is throughout the state of Michigan, and they have senior residents, with continuum of care. And this was really their vision, was to provide the full continuum in an urban setting. And it's a beautiful model and a beautiful neighborhood.
Now, is Presbyterian also the operating entity?
They are in this greenhouse, yes.
All right, just fantastic. Thank you very much.
We have another question about staffing in the greenhouse. What type of staff turnover do you see compared to nursing homes? And then I've heard that hiring the caregiver is a challenge given the range of tasks required. Is that true?
Excellent question. I will say that it's not more challenging. That is a roadblock. I mean, you are telling people who, especially if they have only worked in nursing homes as CNAs in the past, you are saying, well, you're going to have to do these extra tasks. So yes, you will get some people who just say, that's not what I'm interested in doing. But no, that has not, once you get the hiring, the turnover statistics speak for themselves. I can read you a couple numbers here, but the CNA Shabazim turnover in greenhouses was 29%. Wow. The most recent study was in 2021. Between 2017 and 2018, according to a national study of turnover in nursing homes, the CNAs turnover was 129% for CNAs, according to a Harvard study. So it's significantly lower turnover. And I've heard so many stories just in my time at the greenhouse of Shabazim saying, I would never work at a traditional nursing home again because of the autonomy I feel. That is a key part of it too, is that the CNAs often do the most work in nursing homes, but often they're at the bottom of the totem pole in a traditional nursing home, whereas they are the ones driving and making care decisions. They are the ones who decide basically how the community runs on a day-to-day basis. So that autonomy that they get is great. And there's also benefits. I've heard stories of Shabazim who learned to cook for the first time as part of their training. And they say, now I cook these fresh meals that I learned at home for my kids. You know, before that, I was a takeout person because of, you know, it was just cheap and I work very hard, but I actually learned how to cook and I'm making healthful meals at home for my family. So there are knock-on benefits to this system as well. So we won't deny that there's a certain percentage of people who look at the job description and say, I don't know if I want to cook. I don't know if I want to do laundry, but that's minimal compared to the long-term benefits you get from much lower turnover and just the resident engagement.
Yeah, and I would say we've had the same people at the greenhouse that we've experienced. They've pretty much the same. The turnover has been minimal, and I think what also they become part of the family, right? So the staff and the participants, they're all part of a community that they've created, and that becomes the family. So it's not that easy to leave your family. And I think that's what we've experienced. So, and regarding the other duties, I happen to sit on a different board, a veterans board, and they recently developed some brand new nursing homes that are greenhouse model type as well. And they have the universal worker, and they have not had trouble finding staff that way. Now, I say that in the context of COVID and the staffing issues that we're all experiencing, but some people like the variety.
There's another question relating to how much, on average, what does it cost to live in this type of setting? Alex, I suspect there's quite a bit of variation around the country on monthly cost. Maybe if you could express it in the context of we're paid to contract with Greenhouse.
I don't want to be quoted on that because again, it does vary significantly. I will say 49% of residents at the greenhouses are covered under Medicaid. The rest is there are some private pay, as well as there are some greenhouse communities where maybe one or two of the cottages or floors are dedicated to short-term rehab. So there's some Medicare reimbursements there as well. That 49% number, we fully admit we want that to be higher. We want this, you know, frankly, some of the early adopters and some of the people who had the capital and who were able to take the risk on greenhouse were CCRCs, private pay, sort of retirement communities where they were able to take that risk. Because again, I covered long-term care and the for-profit side of the business for a long time. It's hard to convince people who have a model that at least works well enough to keep them afloat to take this big risk. So a lot of well-capitalized private pay communities were the first ones to take the plunge, but we're proud of the 49% number and we want to get that up higher. We are working, some of our policy and advocacy goals are for trying to get some Medicaid add-ons in a lot of states for developing a greenhouse. There are states that already do that. Arkansas is one where you get an add-on to your daily Medicaid rate just by operating a greenhouse small home style community. So there are ways to make this math work out. And you know, Mary, you can probably go into the math a little bit more, but I think what you're doing in Michigan is a really creative way to make sure that, because all of the residents there are covered under Medicaid, correct?
Yes. So, yes. You know, we're paid by Medicaid and Medicare, so we're fully at risk. When we send somebody to the nursing home to live, basically in a basic bed, depending on the nursing home, because it's highly varied, let's just say it's $300 per day, right? It's a savings for us to have them go to the greenhouse. That's the agreement that we worked out. And I'd say it's anywhere from 25 to 30% savings. So it just depends on what your agreement is, what you're willing to do, what they're going to do, what you're going to do, and how you work that out. But I think the greatest commitment is that they're always assured payment from us because we pay for all the beds every day. Now, what that means is we've got to keep them full. And so that's some of the conversation that we are having right now, actually. With COVID, it's caused some stress on that, but we've got to keep the rooms full to make it beneficial. And that's easy for us to refer, but then it's, do they have the staff? And those are all the things that you work out operationally. But I would say there's a great benefit to PACE to think about how you could make an agreement when you compare to the cost you're paying for a nursing home. It should be less. That's what I would say. And a higher quality of life, lower cost.
Precisely. And what I would add to that is that there are more efficiencies. Again, it's the way we pitch the cost structure is you're not paying any more to operate on a day-to-day basis. You're just shifting the costs away from the stuff that doesn't matter as much to resident care, which is administrative overhead. And you're shifting it toward the thing that does matter, which is direct care costs. That's, food. You do save a little bit on food. There's less waste because you're cooking to preference. You're not, making big trays of eggs every morning that just sit and get cold and no one wants to eat and gets thrown out. So there are savings there. And again, yeah, one of the tricky parts is, like every business, it's hard for you to convince someone that if you make this upfront investment now, you'll save in the long run. But it is true. I mean, the turnover figure alone should be enough to justify. Think about how much money you're saving on training and recruitment by having that significantly lower turnover. Think about how much money you're saving by having these better outcomes. There might be some upfront costs that are different, but in the long run, you save money on so many metrics by improving that quality of life. It really is that great connection of providing a better quality of life and also saving overall healthcare expenditures.
There's a series of questions that I'm going to combine into kind of a response that hopefully will address 3 or 4 or 5 questions here. One was about, will my state kind of allow the development of greenhouse? I think the answer is maybe. I think it's something states that have a certificate of need, to the extent that the greenhouse is licensed as a SNF, you probably have to go through the same CON process. Seen Alex shake his head yes. If you're in a state that does not have a moratorium on nursing homes, it would be good to go approach the state. I am aware that some states, if I'm not mistaken, Rich, Pennsylvania has been resistant to greenhouses. Alex, I'm not sure if that's true or not, but
we have one in Pennsylvania, one community. It's on a bigger retirement campus.
Okay.
It's a goal of ours because Pennsylvania, obviously there's aging demographics all across the country, but Pennsylvania particularly has a high percentage of older people who will need, who either need services now or will soon age into the need of needing these services. So on the state level, the CON process is something that we're really working hard, advocacy wise to get carve outs. And again, it's all about working with the state and being upfront. The allowing question, it's tricky because, so much of, and what we try to combat is this compliance bias toward traditional nursing homes, right? There's so many different people on the federal, state, local level, life safety, fire, CMS, all of these different organizations and different regulatory bodies that regulate it for good. I'm not someone who's trying to say we don't need regulations. We do need robust regulations that protect people. But the goal the challenge when you're building a new greenhouse is working with local officials to say, you can meet these regulations and still keep people safe and provide them a better quality of life. One of the key, sorry, go ahead.
Good, no, go ahead. No, go ahead.
I was just say, one of the key centerpieces you may have seen in some of the pictures I showed is a hearth. We want to have a fireplace, some place for people to gather, feel literal warmth, but also the warmth of sharing a warm fire and a cup of coffee with your friends. That freaks out a lot of regulators. They hear fireplace and nursing home, and they're just like, absolutely no. The knee-jerk reaction is no. But in our experience, when you bring them in, when you show them the plans, when you explain to them that this has been done hundreds of times before across the country without disaster, then they will usually come around to that. The same thing with having secured access or access to secured outdoor spaces. That is something that kind of makes regulators a little bit uncomfortable because you think of people who might, go outside. There are ways that you can sort of thread that needle between safety and autonomy. And that is a huge tenet of what we believe at the greenhouse, is that no matter your age, And no matter your abilities, you don't sacrifice that autonomy. You're still able to make decisions for yourself, and you balanced with safety. And so that is a key that, that when you talk about allowing, that's a key thing, that it does take a little more work, but generally they are receptive, because I think especially post-COVID, we're well aware of the danger of having the traditional model.
There's also questions relating to how we, so with respect to a PACE program that has an individual that needs a skilled level of care, yeah, we're financially responsible, kind of operationally, clinical, service-wise responsible. The scenario would look like if there were a greenhouse down the street, we would establish a contract with the nursing home or with a greenhouse that would be tantamount or equivalent to what we would do with a traditional SNF. We would negotiate a daily payment, and they would be rendered care in a fashion that's very similar to how we would manage that in a traditional nursing home. There's also a question about, would they come to the PACE Center? I have no doubt, similar to nursing home residents, they would probably come to the PACE Center on occasion, as nursing home residents often do. So it's many ways, it's equivalent to how we would manage the care for an individual in a nursing home from the standpoint of payment, oversight, and integration into the PACE program. There's also a question about, can we pay for housing? If I think this is right, there are a few greenhouses that are not licensed at the SNF level. And in some states, states have concerns about us paying the room and board portion of that assisted living. And in those instances, I think as Luke mentioned here, you would have the individual participant pay the room and board portion out of their SSI, out of the Social Security SSI, and then you would bifurcate the service component, and that's what would be in the contract. So actually the PACE program is paying for services, not room and board. It's a very easy approach. And then I think there's a question about greenhouse PACE projects for veterans. Yeah, Mary just mentioned there's one in Detroit, evidently, that popped up.
Actually, in Michigan, we've just built 2, and there's more to come. They've done one in Chesterfield Township in Macomb County and one in Grand Rapids.
That's great. And hopefully there'll be more. And then it says
Yeah,
also
also,
for residents. In the case of Mary's program, it's owned by one of the sponsors, Presbyterian Villages of Michigan.
Right, and we own the one in Pontiac.
They own the one in Pontiac. But I will introduce now some, thoughts and ideas, some things that Alex and I talked about. What about a PACE program in a greenhouse in a common market, collaborating on either the development of a new greenhouse that's dedicated solely for PACE participants? That could either be a capital partnership, or the greenhouse could move forward, or the PACE program could move forward. Maybe have the greenhouse operate it under contract. There are a lot of different opportunities here where you exist in common markets. PACE programs that aren't in markets with greenhouses, it may be something to look at. I use the kind of metric, the average PACE programs, let's call 400 people, a little bit north of that. So on any given day, you got 20 people under contract in a nursing home. That would easily fulfill the needs to occupy a greenhouse and more. So these are all kind of things to think about. And then I want to there's a lot of questions, you guys, so I'm sorry if I'm kind of blasting through this. They want to know how our 2 models of care did under COVID. We talked about that right before the call. Alex, do you want to address that? And then I'll mention it for PACE.
Yes, I shared a link to our COVID research on our website. We have some charts and graphs that are probably easier to parse, but yes, many orders of magnitude lower. Obviously, greenhouse communities were not immune to infection and death due to COVID-19, but just from the first 3 quarters of 2021, the number of cases in greenhouses were about 1/3 of the national total, and the deaths were about 5 times lower. And there's a few reasons for that. One is the private rooms and the private bathrooms. We know those areas where people are performing intimate tasks, where you need help during intimate moments. If you're helping someone use the bathroom, it's very difficult to keep distance or to not potentially share aerosols. But it's also the result of the staffing model. There are fewer people coming in and out. The universal caregiver means you don't have separate housekeeping, separate dietary, separate CNA staffs coming in and out. So it's twofold. One is the private rooms and bathrooms, which I think people understand intuitively. But the second part of that is fewer people coming in and out. the same consistent people working with the same consistent groups. Ideally you have the same team working in the same house on a greenhouse campus, not sharing among them. So there's lots of different infection control advantages as well. And that's not just COVID, that's flu, that's pandemics that we don't yet know about, that's new variants of COVID, all of it works.
Yeah, in the context of PACE, the answer is the likelihood of having contracted or died from COVID is about 2/3 less than it was in a nursing home. And Alex's point about they're in an institutional, there's kind of two sides of the coin of institutional risk. One, if you're small, you have, obviously, if you look at the metrics that are coming out of greenhouse, you have a lot more control to kind of contain the virus, I think, and that's evident, I think, in the figures. On the other hand, I think, large nursing homes, it's a lot more difficult. And I think the large scale loss that you saw in nursing homes was really a product of congregate design. We in PACE, I learned during the pandemic, a lot of our folks live in multi-generational families that aren't necessarily well-to-do. Many of those people that live in those families have to get out during the day and work and come back. That is an inherent risk that our participants faced, that we did our best to really mitigate. And I think that's why you saw our rates, again, 2/3 lower than nursing home, because there was just such intense effort put on protecting residents and balancing that with continuity of care. There are other questions, just a lot here. There's a question about, wow, where do I begin here? I think the answer to the question, does Greenhouse or PACE employ the CNAs? In the case of Mary's situation, it's Greenhouse employs the CNAs or Shabazz. PACE program does all the wraparound services with PACE staff. Oh, this is a really good question. Sorry, Luke, it's a really good question. In the context of states' definitions relating to rebalancing care, does Greenhouse, is Greenhouse definitionally considered community-based, or is it, does it add to that weight of calculation, or is it considered an institution?
Good question.
That varies by state. That is a very good question. And I think a lot of states are currently trying to sort that out. AARP Michigan just put out a report where they are advocating for greenhouses to be included as community-based in that rebalancing to provide those incentives. Again, that is an area where we're working really hard advocacy-wise, is getting, we fully support the rebalancing of care. As I said before, we want more home health, we want more PACE programs, we want more adult day, we want more everything, because we're going to need everything in order to create a full continuum. And so we are advocating for those carve-outs, whether it's a CON carve-out, whether it's a bonus, whether it's considered maybe not fully community, but somewhere in between community and traditional nursing home. It's a key area of advocacy, and I think a lot of states they don't know the answer to that. They're still trying to figure that out.
Let's hope they come around and consider it to be its community. There's a question about how big is a PACE center? How big is a PACE center? How much space? Huge variation. Mary, you can speak to that, but there's
Huge variation. So
10,000 to what I've seen centers up to 50,000 square feet. So yeah.
right. We started about 25,000 square feet and go up to 35,000. But our centers start at serving 300 or more, just based on the population needs.
And there's huge variation. If you go to some of our rural programs, as you can imagine,
Yes, not going to be that.
I've seen in some of our rural areas, I mean, they were in pole barns, really small little buildings, tiny little buildings. So there's a huge variation in that.
It really depends on how large you're building it for. What's your population going to be in that center?
There's a question about cost benefit analysis and ROI. I see such data readily available. One thing for the person that's asking the question about kind of the financial aspects of PACE and Greenhouse, as it relates to PACE, you can go and run a very high level pro forma on our website. It's free. It's a pivot table. So behind it are rates, utilization factors that you can't really change. But that would be one way to look at it. A general rule of thumb, it's somewhere between $3 and $9 million to start a PACE program. There's huge variation here, but these are the general rules of thumb. Typically break even about 150. which takes you a couple of years to get to, takes you a couple of years to develop a program. So you're arriving at the 4-year mark when you're breaking even. This is truly God's work. And then ROI comes kind of shortly thereafter, depending on whether you've capitalized the center. A lot of it depends on whether you choose to lease or capitalize, whether you're buying your vans, leasing your vans. There are a lot of moving financial parts in PACE that lead me to simply say it depends. But
Right,
you
and I
can
would
mimic
say-
that. Yeah, go ahead, Mary.
I was just going to add, you don't have to build new. None of our buildings are new. We redevelop buildings that exist and find the right size. And then we have the owner redevelop and we lease. There's lots of ways to do it. That's all I would say. There's lots of ways to get it done.
Mm-hmm. Yeah, Mary and Alex, you might want to jump into the chat and look and see if there's any questions that jump out. These are getting varied and voluminous, so I don't want to leave anybody's questions behind, but some of them are very specific.
Well, this
relating-
one about the economies of scale for developing the village group home. I would say we've experienced a lot of economies of scale because it's all on the same campus. So when you have 20 participants that reside there right on your campus, you're not transporting people back and forth. Just that alone is a huge thing. Talk about the ease of communication and being able to access them right away and prevent declining condition and not feeling the need like they have to call the emergency room, that sort of the ambulance 911, that sort of thing. So there's a lot of economies that you gain just by being together. And I would think that even if it was not on the same campus, but we had that kind of relationship, it could do the same. There are a lot of economies of scale that you can benefit from.
I want to respond to something that Joseph Rani just said about privately owned residents with residents who are responsible for the food and non-care services, and then PACE comes in and provides additional services. There's a model like that. I don't know if it's individual condos or apartments. There's a model like that here in Illinois where I live, where it's called supportive living or supportive housing. And there's a lot of interesting, very cool models where basically a senior apartment complex, everyone has their own individual units, but there are on-site medical providers, on-site specialists. So it's sort of like assisted living, but it's really designed to not be a high-end product. It's designed to be for everyone. So I suggest you look at it's called Illinois Supportive Living. There are a couple of developments here in Chicago where I live and also around the state. So that's another very cool model. And again, just to emphasize what Sean said earlier about the partnership potentials, we're open to any and all ideas. We're not doctrinaire about many things. In order to be a licensed, officially licensed greenhouse, you can't have more than 12 people per home or floor if you're a high rise. You do have to abide by the Shabazz model. But we are open to, we are really passionate. Like Sean said, it's God's work. We're doing, we're not in this for the money. We really do want to provide as many different options and creative partnerships as possible. Mary's collaboration with Presbyterian Villages of Michigan is an awesome example of what can happen when you step in and say, hey, how do we make this work? She was just featured in Canada, all across Canada, on the CBC, which is their national broadcaster, because some folks up in Ontario got inspired by that collaboration, and they're trying to make something work. Obviously, PACE, it's not called PACE because they have a different program up there, but they're really working to make something happen. I really want to emphasize, I will put my email address in the chat here, and I encourage everyone to reach out to me if you have questions or if you have ideas, because really what we want is to create what's best for elders and to create an adaptable model. So we're open to any and all ideas and any comers to have that discussion.
And I welcome any questions as well about how to operate it, the way that you can work it out together.
Good. Well, we're wrapping up toward the end of the call. I hope everybody's found value in this. As I mentioned at the beginning of the call, and it bears repeating at the end, each of you will receive a follow-up. It'll be kind of a one-pager PDF front and back. It's going to have a map of where PACE programs and greenhouses are located, probably color-coded by where there's overlap, and then you can flip it around and you'll be able to see contact information for close in proximity situated greenhouse and PACE programs. My hope is that each of you here does a few things moving forward. One, if you want to learn more about greenhouses, contact Alex and go to their website. Two, if you want to learn more about PACE, feel free to go to our website, contact myself. And Mary mentioned she'd love to talk to you about her greenhouse arrangement or PACE. And then also, it'd be good for you all to begin thinking about, is there a better way, in particular in the PACE world, is there a better way moving forward to develop strategies to find more, I think, evolved approaches to congregate living for our participants that need care beyond what is possible in their homes. And I really believe in my heart of hearts, greenhouse is it. I would love to see, my view and my passion really is where we have to acknowledge that there will always be a subset of people we serve that are most appropriately served in a congregate setting. Why not let that be a greenhouse? So, we are two very complementary models. I really like to see the future, us to evolve together in common markets. And I think that the mission of our organizations is very compatible and lends itself, I think, a lot to collaborations, either contractually, capital wise, or strategically much broader than the individual things that we do today. So thank you very much for participating. And again, if you guys have any follow-up, feel free to let us know. I think all of us are available and receptive to answer any questions, have an additional discussion. So in closing, I just want to say thank you to the presenters. I know I'm taking some time and effort to do this, and I really appreciate it. So thanks to everybody on the call. Hopefully enjoyed it, and you'll get some follow-up materials very soon.